Hello, Daniel. And so how does TB present to a pediatric surgeon, and what is the role of a pediatric surgeon in management of patients with TB? And we are really honored to have Professor Larry Hadley as our invited guest for today's talk. And those who do not know Professor Hadley, who I think is extremely unlikely here in our country and in Africa, he he's a very senior pediatric surgeon, is now retired from University of KwaZulu-Natal in Durban, and he's a well-renowned pediatric surgeon and pediatric surgical oncologist. He also has special interest in the tropical diseases like the TB and the HIV and parasitic infestations as they present to pediatric surgeon. So we'll start with today's talk. Daniel, you can start your talk, please.
Thank you, Prof. Good afternoon, everyone. My name is Daniel Erwee, and I'll be speaking about the TB and the pediatric surgeon. So firstly, the reason why we are speaking about TB is that TB is one of the great mimickers that has very unusual presentations, and you need to have a high index of suspicion to reach the diagnosis. The clinical and radiological findings of extrapulmonary TB are also non-specific, and TB is one of the top 10 causes of death globally. A quarter of the global population also has latent TB, and the management are getting more complex with things like multi-drug resistant tuberculosis as well. So for the diagnosis and management, it's important to have, like we said, it's a great mimicker. So you'll need to check for clinical, radiological, laboratory, as well as pathology features of TB to help with diagnosis and management. So firstly, if we look at radiological assessments, so firstly, your chest X-ray. If you have TB in your chest, it supports the diagnosis, but it's important to note that TB, if you don't have TB in the chest, it doesn't mean you don't have abdominal TB. With abdominal X-ray, you look for features of air fluid levels, fixed bowel loops, and pneumoperitoneum, interception or calcification in mesenteric lymph nodes, as well as evidence of ascites. With the contrast studies, you can do small bowel barium meals or barium enemas, and then you look for signs of 3 different morphological types. The first one is ulcerative, then hypertrophic, and then ultra-hypertrophic. With the ultrasound, that is helpful in peritoneal and nodal TB. So you can also identify thickened and dilated bowel loops via ultrasound. And you are also able to do then ultrasound-guided FNAs or cytic taps, or do biopsies from lymph nodes or hypertrophic lesions. When we look at CT scans, it also helps us differentiate from other inflammatory and neoplastic diseases like lymphoma and Crohn's disease. For TB, you look like specific nodes that gets involved, mesenteric nodes, celiac nodes, portohepatic nodes, and peripancreatic nodes. With further investigations, as you can see, there's quite a lot of them. Hematologically, you might find that the child presenting has anemia, low albumin, a leukocytosis, and a raised ESR. A raised ESR is not specific, but it helps with monitoring to the treatment, the response of the child, if the treatment is working. With a Manto test, if it measures less than, if it is used for patients less than 5 years, so a measurement of 10 to 14 millimeters shows that there's active infection. And if the Manto test is more than 14 millimeters, the child has 4 times the likeliness of having TB. With the AFB, that's the acid-fast bacilli. This can give you a preliminary diagnosis, but the problem is that you can't distinguish between the different organisms, and the result comes out as a 1+, 2+, or 3+. These might also be negative in the early disease process, and you need quite a high load of them, 10,000 organisms per millimeter to be positive. When we look at cultures, this is a definite method of diagnosis, and it's more sensitive than smears. And you only need 10 AFBs per millimeter to be positive. You can also then identify the specific species, and you can test them for different drug sensitivities like MDR and XDR TB. Because it's such a slow-growing organism, this takes really long to have. So it takes about 6 to 8 weeks, but you can have a faster result out if you use TB growing media, which is available in the States. Then if we look at gene experts, the sensitivity and specificity in smear-positive cases is more than 95%. But if the smear is negative, it decreases to 40 to 70%. And when you have the result, that can tell you about RIF resistance immediately. So it means that there's a fast result available, you can start treatment early, but it doesn't tell you of any other resistance. So if there's RIF resistance, you need to further investigate. Then with your immunoassay, it's a new test that's available. It's quantiferon. It's a presence of interferon gamma release protein. And this is more specific than a Manto test, but it's only recommended as a screening tool as well. Then with further investigations that the pediatric surgeon gets involved in is colonoscopies and laparoscopic investigations. So firstly, on a colonoscopy, you look for ulcers, you look for strictures and edematous and polypoid mucus folds. A pathognomonic feature is when you find a pinkish, non-friable mucosal nodules that has different sizes, and in between those, when there's ulcerations present in a segment of a colon. Those are most often present in the cecum itself. And with a colonoscopy, it then gives you opportunity to take multiple biopsies from the edges of the ulcers. You can then send for AFB smear and a culture, and you can also send for PCR and histology. The limitations of a colonoscopy is that if a patient had previous TB treatment, it alters the histology of the biopsy. With the laparoscopic appearances, so sometimes visual appearances are more helpful than histology or culture, and you look for 3 different types of appearances. The first one is a thickened peritoneum with tubercles. The second one is thickened peritoneum without tubercles. And the third one is fibroadhesive peritonitis, which you can then see markedly thickened peritoneum and then multiple thick adhesions that fixes the viscera. So just with further workup, if you're able to do a CT tap, which might be quite good to help you with your diagnosis, you look at a specific type of picture with this CT tap. So normally the color is straw colored with glucose less than 30 and high protein more than 3. The cell count usually is more than 1,000, but you can see it ranges from 150 to 4,000. And then you need to look at your ascites to blood glucose ratio. That's less than 1. Your serum ascites albumin gradient, that's also less than 1.1. And then your ADA, which is more than 36. It's important to note that with the ADA, if there is HIV co-infection, it can still be normal or low. So you can't just go on the ADA. You also do then your culture and your AFB smear. But these anesthetic taps is only positive in 10 to 15% of cases. They say that if you tap 1 liter of fluid and you concentrate that via a centrifuge, it increases sensitivity. But with our children that presents, you might not be able to get 1 liter of aseptic fluid off as well safely. So also then with your PCR, it's rapid and it's reliable to identify peritoneal TB, and it gives you a quick result. This causes then that you don't go unnecessarily for surgery, and you can start early with your TB treatment. If we look at a diagnostic approach with suspected abdominal tuberculosis, it's important to know which type of tuberculosis it is, because the approach is different for all 5 of them. So firstly, you have a wet peritonitis there on the left side. So that's when you have free ascites or localized fluid. You can do aspiration, like we said, and test that. And then if that doesn't help, you can do a laparoscopy. Second one is a dry peritonitis, and that is when there's peritoneal nodules and dense adhesions. And you also have the fixed fibrotic type. They have matted bowel loops and a thickened mesenterium and omentum. So with these fixed and dry ones, laparoscopy may be more difficult because there's a higher risk of iatrogenic bowel injury and fistula formation, and there's no space to insert the laparoscope. In these cases, then a laparotomy might be indicated. Thirdly, you have lymphadenopathy, so then you can go via ultrasound-guided aspiration. If that doesn't help with, then you can consider laparoscopy. With intestinal, you do endoscopy, and with solid organs, you also might consider doing ultrasound-guided aspiration. It's important to note, even though there's 5 of them, there's also a 6th one that you suspect abdominal TB, but you can't prove it. So then you can have a therapeutic diagnosis. And they normally, you start with anti-TB treatment, and they have a rapid response to it, normally within 2 weeks. So if we look at surgery that's involved in abdominal TB, so 25 to 30% of the cases presents at emergencies. These emergencies might be presentation of perforation or acute intestinal obstruction that doesn't respond to your conservative measures, acute peritonitis, and then rarely you can have significant hematoschisia. With the TB perforation, it's usually ileal, and it's also associated with distal strictures. So then a resection and anastomosis is preferred, and simple closure is not recommended because it's associated with a high index of leakage and fistula formation, and that causes higher mortality. With ileocecal, it's recommended to do a limited resection of the ileocecal area rather than to do a formal right hemicolectomy. The reason is that there's then lesser dissection and lesser chance of injury to the duodenum or ureter. With colonic ones, resection is advocated. And then with the mortality, as you can see, with intestinal obstruction, emergency surgery is best avoided. So if you can manage that conservatively, that is a better option. The mortality is high. You can see at the bottom, they're also for less than 5 years of age. The younger they are, the higher the mortality. And the mortality is high because of associated problems of malnutrition, anemia, low albumins, poor wound healing. And then some of the patients just has a worse prognosis, like patients that has disseminated TB, miliary TB, or TB meningitis with your abdominal TB. So when we look at laparotomy, it's advised to rather have 2-week empirical TB cover that you started them on treatment, but this is also controversial. The reason for this is that it might assist to reduce the chances of spreading of the active infection when you do the laparotomy. And with surgery, the aim is that you have minimal intervention and that you should avoid major operative procedures. So it might just be better to do a bypass surgery to relieve the symptoms, because a surgeon can't eradicate TB alone. You can have procedures like external diversions, internal diversions, closures of perforations, and a strict uroplasty. And surgical resections are less commonly performed. So complications of abdominal TB, you can have subacute intestinal obstructions, you can have adhesions, intestinal strictures, malabsorption, or short bowel syndrome. It is also of note to mention about genitourinary TB. So genitourinary TB is uncommon in children. The reason is because symptoms of renal tuberculosis doesn't appear for about 3 to 10 years or even more after the primary infection has started. So it's very, very unlikely that you see a case of genitourinary TB in children younger than 5, but as the age progresses, as they get more into closer to adult ages, then the incidence will increase. There was a study done that was published here at the Journal of Paediatric Urology. And this study viewed case records of 17 children that was diagnosed and admitted at their center over 15 years. And as you can see here, if you look at table 1 there at the bottom first, the most common clinical features that these patients came in with was irritative voiding symptoms, constitutional symptoms, and hematuria. So if you see a patient with a query UTI, TB should always be at the back of your mind as well. With the investigations at table 2 there on the right side, you can see that all of them had pyuria, 100% of the cases, and 88% of these cases could be diagnosed radiologically. So the radiological abnormalities included that there was calcifications, there was cortical scarring, calyceal cavitation and destruction, non-visualized kidneys, urethral strictures, or irregularity and a small capacity bladder. So with genitourinary TB, a minimum of 4 weeks of drug therapy is recommended before doing any surgical intervention. With medical treatment, you can classify them into 3 different types. So with the surgeon, you would more likely see TB lymphadenitis. That's an uncomplicated one. But abdominal TB or any TB with HIV co-infection counts as a complicated TB. So with the medical treatment for that, the uncomplicated ones like the TB lymphadenitis, you can see that it's only a three drug regime. So it's rifampicin and isoniazid and pyrazinamide that is used as the intensive phase for 2 months. And then you go over to the continuation phase for 4 more months. So then it just goes to rifampicin and isoniazid. But if you have a case with complicated TB, so that's the one that we said abdominal TB falls under, as well as any patient with TB with HIV co-infection, then you add your 4th drug, which is ethambutol. So just a quick word about MDR TB. So risk factors for them is children that is in contact with people that has MDR TB, or residential areas that has high prevalence of this MDR TB, as well as HIV co-infection. In Uppington, where I worked before this, there was a MDR as well as a XDR TB unit. And in that areas, there were specific families that was known as the MDR or XDR families, as they had severe problems with compliance. And the problem is when the adults have severe compliance issues, the children come in with MDR and XDR TB. So they needed them to be admitted and then handled from there on. So just principles on treating MDR. You should never add a single drug to an already failing regime. And if you have resistance to INH, 2 other drugs that has been shown sensitive on that specific culture should be added. With MDR TB, you get 3 different types. So you get only drug resistant, which is a monoresistance to either INH or rifampicin. And then you get MDR TB, which is resistant to both of them. And then XDR TB is resistant again to both of them, as well as a second-line drug. So the problem with this is that there's prolonged complicated regimes, and the medication has severe side effects and it causes compliance problems. So that's why it's so important to involve the pediatricians and to have MDR and XDR TB units that specializes in this. Just to show you a quick complicated MDR regime. So as you can see, there's a lot of drugs there and all of them has side effects. So South Africa first had an injectable regime, but now they have phased in injectable-free regimes. So you have a short regime and a long one. So the short one is a regime for 9 to 11 months, but there's a specific criteria that should be met, and that criteria is about 1 page long. If you don't fall into that, then you go on to the long regime, and that can take up to 18 to 20 months. The drugs that we see here is linezolid, PAS, levofloxacin, clofazimine, isoniazid, pyrazinamide, and ethambutol. So you can see it's quite complex, and you need to be quite specialized to understand these things, which I don't. So that's why it's important, again, to involve the pediatricians and the TB units. Also, a quick note on HIV and TB. So when you have a child that's co-infected with HIV, the manto can show, has poor sensitivity. So you can't only go on that. And then your symptom-based diagnostic approach is less helpful because the TB-related symptoms can't be differentiated from other symptoms caused by HIV-associated conditions. And that's also, you need appropriate supportive care. As a patient on TB treatment with ARVs, the treatment changes. And they also need prophylaxis for opportunistic infections like crotomoxazole. So again, important to involve the pediatrician. So TB is not only a main pathology, it also is a comorbidity. And because South Africa has such a high incidence of TB, a lot of our patients can come in with different problems with TB as a comorbidity. So this was a study done by Prof. Hadley. It was a retrospective prescriptive study of HIV-infected children that had malignant solid tumors, and they studied a group of 18 children. They used fluorodeoxyglucose PET scan to try and differentiate between metastatic disease and inflammatory disease. And it was very difficult. The reason why they did that is because it's difficult to distinguish pulmonary or nodal TB from metastatic disease if you don't use invasive techniques. Also, that abdominal TB can be difficult to distinguish from an extension of abdominal malignancy itself. So they concluded and advised that all suspicious lesions should be biopsied to confirm the presence of malignancy, as the staging on clinical and radiological grounds may only result in overstaging of some patients, and then in other patients, you may fail to detect a treatable comorbidity like TB, which might improve the outcome of the patient. The comorbidities, if you have a patient with TB as well, it worsens the nutritional status of the patient, and they are then less likely to tolerate surgery and standard chemotherapy regimes. And these comorbidities causes that patients has poor anesthetic and surgical risks, and the mortality is quite high. Thank you so much. This is my reference that I've used. Thank you.
Daniel, yes, Daniel, that is excellent presentation and a very good overview of this complex problem, and very well done. Now, please stop sharing your screen, and then I will open up Prof. Hadley's presentation. Prof. Hadley, welcome. We are ready to go.
Thanks very much, Milind. Yeah, I enjoyed that presentation, and it's great to see that somebody other than my mother actually reads some of the things I've written. Thank you very much, Dana. It's also lovely to see some old friends on the list of participants. So, Lulama, Arturo, thank you very much for joining us. I've got a slightly different take on TB. Could I have the next slide, Milind? When I started training in the Middle Ages, I was very fortunate to fall under the tutelage of this gentleman, Bob Mickel, a paediatric surgeon extraordinaire. And he gave me lots of advice and tips. But the one tip he gave me that has been particularly useful, he said that if ever you're in an exam or you're on a ward round, a teaching ward round, and somebody asks you a question, you have not the first clue what the right answer is, then you have two options. You can either say, well, it depends, and that gives you a second or two to think about what it might depend on. Or you can say TB, because TB can do anything to anyone. Okay, the next slide, please. Certainly, you can't exclude TB on the basis of age. Here's a patient who was born with congenital TB. And so even the very small baby, you've got to be thinking of the possibility of tuberculosis. Next slide. And obviously, TB in the neonate usually is related to placental tuberculosis, which is something we've been seeing more often during the HIV pandemic. Next slide. So there's lots of ways you can get tuberculosis. You can inhale it, and that sometimes causes, if it involves a tonsil, you get tuberculous cervical lymphadenitis or pulmonary TB. You can eat it, which will give you, or drink it more usually with milk straight from the tuberculous infected cow. That gives you intestinal TB or peritonitis. You can be inoculated with it. And we often see small children who come at the crawling stage, who have been crawling around the floor of a mycobacterial laden floor, where the adults have been coughing onto the floor. The children, they crawl, get scratches, and they develop inoculative abscesses. It can spread through the bloodstream, so you can get extrapulmonary TB, and that's how your bone and joints and spinal TB occurs. And as I said, you can get congenital TB through transplacental spread. So there's lots of ways you can achieve the goal of getting a tuberculous infection. Slide, please. Scrofula is the old term for cervical lymphadenitis. This is probably, as Denard said, probably the most common extrapulmonary site of infection. And you can see these big lymph nodes. I mean, they look like those chocolates that you get with a soft center. There's a rim of enhancing granulation tissue, and then the caseation looks like a soft center. But you can also see how they can lie adjacent to the airway, and they can threaten airway stability. So this is a potential disaster. Hello.
Sorry. Somebody needs to just mute yourself. Sorry, Prof.
Everybody all right? No, is everybody back on stream? Okay.
Yes.
Now, if these abscesses are drained, and sometimes they are because they're mistaken for pyogenic abscesses, if they're drained, then you end up with a non-healing sinus, which plagues the patient ad infinitum. Next slide. Now, this is not a new disease. This is a 14th century illustration of the surgeon and the anaesthetist. And they're treating, as you can see, the scrofula sinus opening in the neck of the poor patient, and they're going to treat it with cautery. Now, perhaps somebody in the audience can read this legend more readily than I can, but I think it says cautery of scrofula sinus openings does not work. Next slide, please. The same team of surgeon and anaesthetist also developed an operation for hydrocephalus, and that doesn't work either. I have no idea what anesthetic agent this guy is using, but it's remarkable that the child is alert enough to be able to watch his head fall onto the floor. Next slide, please. The Europeans, of course, far more sophisticated. The Europeans treated tuberculous cervical lymphadenitis by having the king touch the patient. And both the French royal family and the English royal family were skilled at curing tuberculosis by touching the patient. And this was done with incantations from priests, and of course, the crowds gathered to witness this event. It didn't work. Next, if it worked, we'd still be doing it. But we mustn't get too pompous because surgeons can't cure TB either. What we can do, as Anna said, is we can make a diagnosis. Now, if patients came to us with tuberculosis as their primary pathology, then life would be very simple indeed, but they don't. Tuberculosis is nearly always a confounding pathology in our practice. And sorting the tuberculosis from the primary pathology is often difficult. And of course, we are able to relieve emergencies. And those, as you've heard outlined, are intestinal obstruction and perforation, abscess formation with airway compromise, spinal cord compression is a particularly distressing presentation of tuberculosis. And we can manage exsanguinating hemoptysis sometimes and pulmonary destruction. This slide. Right. The problem, as you've had outlined already, is that extrapulmonary TB mimics malignancy. It does it clinically and it does it radiologically. Collecting sputum in children is really a very taxing exercise. Even with the help of skilled physiotherapists, it's unrewarding at best. Culture of mycobacterium is difficult and it takes forever. You visibly age while waiting for the results of a TB culture to come back. The non-invasive tests, such as the NAN2, the interferon gamma, whatever, and the ADA, the psyches, are pretty much unhelpful in the sort of situation we're talking about. And even histology can be indeterminate if they can't see AFBs, if the AFBs aren't there in sufficient numbers for the pathologist to see them. Slide. So making the diagnosis of TB is difficult. So this is a child who came into us with a nephroblastoma. This is a CT scan of his chest. What are we going to do? It doesn't look like metastatic disease. And because we didn't know, we said TB, and we started treating the child. And the child did very well. So we were probably right, but we didn't confirm our diagnosis. Next slide. Then what do you do about this lesion in the right chest here? Doesn't look like TB, doesn't look really much like anything else, but the child's got a malignant tumor. Could it be a metastasis? Well, because it's peripheral, we were able to put in a thoracoscope. Now, when I say we, I mean Mr. Shaker Four put in a thoracoscope and biopsied it, and it's an intrapulmonary lymph node. I didn't even know we had intrapulmonary lymph nodes, but apparently we do. And if you have intrapulmonary lymph nodes with HIV lymphadenitis, this is what they look like. Next slide. Thanks, William. You can see this small lesion at the back of the left chest here. And again, the child has a nephroblastoma, and we're worried that this might be a metastasis. And that is a critically important decision, because if this is a metastasis, then the child's going to have more aggressive chemotherapy with a higher complication rate. He's going to have radiotherapy. He's going to be in hospital for longer. And if it's not a metastasis, whatever it is, needs treatment. And again, because it's peripheral, we were able to put in a thoracoscope and make a diagnosis. And if any of you have guessed what this is, I'll take you out to dinner. This is pulmonary schistosomiasis. Next slide. Now, sometimes radiology is exceedingly helpful. Here you can see the patient with paraplegia, and I don't think there's much doubt that this is tuberculosis. You can see that there's collapse of some of the upper thoracic vertebrae. There is loss of the disc space. There is a mass lesion under the anterior longitudinal ligament of the spine, and there is an intraspinal lesion compressing the cord. So I think to say that this is TB, where one could say with a fair amount of confidence. Next slide. But now, what are you going to do with this? Patient comes in paraplegic with bilateral Wilms tumor, right? And this is the picture that you're faced with. You can see that there is the same collection of, let's call it a collection of whiteness underneath the anterior spinal ligament. There is a change in signal in the upper, probably lower thoracic vertebra, and there is a mass lesion in the spinal canal. Now, this is a situation that I think it's very important that we operate on these children urgently. If you wait and faff around trying to make a diagnosis here, the paraplegia is going to become permanent. If you operate early and relieve the compression of the spine, on the spinal cord, then the paraplegia can resolve, as it did in this instance. So we got our neurosurgical colleagues to assist us. We decompressed the spinal canal, took biopsies, and this is in fact intraspinal nephroblastoma, which is extended through the neuroforamina. But it's a critically important decision to make, because if we had treated this as tuberculosis, the patient would be paraplegic still today. Slide. It's difficult when it comes to mediastinal nodes. Our colleagues in cardiothoracic surgery are very used to doing mediastinoscopies, but we're not. And so mediastinal nodes is the one situation where I'm always very tempted to treat the patient without a histological or confirmatory diagnostic test. Next slide. And of course, TB and tumour do occur together very frequently. Here is a child with a Wilms tumour, as you can see very clearly there. And this second mass in the lower abdomen is in fact tabes mesenterica, the thickened cake-like omentum of peritoneal tuberculosis. So again, it becomes important to be able to differentiate between the two. If we had just thought this was all nephroblastoma, the patient would not have got his tuberculosis treatment. Slide. Now, this X-ray was sent to me by colleagues in Pietermaritzburg, who had this child present to them, and they sent it down to me and said, "What do you think?" Well, I looked at this, and in my defence, I have to say I was looking at it on a mobile phone. But you can see that the left chest is full of tumour, that it's extending either from the chest into the abdomen or from the abdomen into the chest. And there's not a lot of things do that. One of the things that do that, of course, is neuroblastoma. But there is displacement in mediastinum, there's a mediastinal mass, and probably a bit of splenomegaly, but there's certainly no lung visible on the left. Next slide. And if we look at this and the transverse cuts, you can see that the left hemithorax is full, the heart is shifted across. Whatever it is eroded through the chest wall adjacent to the sternum, and is beginning to look like a chocolate with a soft center. But I still, in fact, favored an aggressive neuroblastoma. So the plan was to do a needle biopsy, which our colleagues in Pietermaritzburg did, and showed this was all tuberculosis. So it's important to think of tuberculosis, and if you don't know, always have tuberculosis as part of your differential diagnosis. Slide. And just to give you some illustrations from the paper that Danielle referred to, the idea of using a PET scan is that if you have an SUV, which is a standard uptake value of which is basically just a sum, where you take a background count and count over your lesion of interest and divide one by the other. If you get an SUV over 2.5, it is strongly suggestive that the lesion is malignant. If it is under 2.5, it is strongly suggestive that the lesion is inflammatory. So here's a child who's got an abdominal neuroblastoma, and you can see well from this scan why we say an abdominal neuroblastoma feels like a bag of potatoes under the skin. And he's also got this lesion in the neck and with an SUV of 3.6. So we biopsied it, and it is indeed metastatic neuroblastoma. Slide. And then you get a chap like this. He's just had a sarcoma resected from his thigh, and you can see the metabolic activity, which is taking up the glucose, the radiolabeled glucose, in the thigh with a circle around it. He's got generalized lymphadenopathy, which is not terribly strong in uptake of the tracer, but he's got intrapulmonary lesions, he's got a mediastinal lesion and he's got a lesion in the neck. The darkness in his head, of course, is just a manifestation of the fact that the brain uses glucose as its only energy substrate. And so you can't use this technique for looking at anything intracranial. So we biopsy this, and this is indeed tuberculosis in the neck. The lymph nodes are HIV lymphadenitis, and the lesions in the lung are metastases. But the SUV of 3 was misguided us because that is a tuberculous lesion, an inflammatory lesion, not a malignant lesion. Slide. And here's another example, an SUV of 2.9. Child is on follow-up having had a stage 2 nephroblastoma resected. And the PET scan is trying to tell us that these are malignant axillary nodes. Well, nephroblastoma doesn't usually metastasize to the axillary nodes. In fact, I guess if I was to say it never metastasizes to the axillary node. So again, we were misled by the SUV, and this is in fact HIV lymphadenitis. Slide. So to sum it up, as Danella said, all children are at risk of TB, but especially the poor, the malnourished, the HIV infected, those with malignant diseases. And it's important to remember that those children whose parents have any of those characteristics are also at risk of TB. If you don't know the answer, say TB. Biopsy whatever you can, because you're making critical decisions that are going to affect the child's life. You can't afford to do that on assumptions. You culture it whenever possible, but don't hold your breath while you're waiting for the results. Treat whilst you're waiting for the results. Thanks, guys.
Thank you, Prof. That's, as usual, a very excellent take on TB, lots of experience behind it. And I especially loved those images of the PET scan and their interpretations. I see Professor Colin Lazarus is also with us, and I know for sure that he had massive experience of treatment of tuberculosis of the spine. Today we didn't include TB of the spine and bones in Daniel's presentation, but I also know that Colin has done some cases of TB spine in children, because I remember assisting him when we started here in '95. So Colin, you can give your opinion, your comments, please.
So Milind, thank you for that. But I really do want to thank Danelle for her presentation and the introduction, and Larry for your superb slides and the thoughts that you have about TB that have gone into your presentation. Milind, I'd like to come back to that, and if you would give me an opportunity right at the end of the meeting,
Sure.
I'd like to talk about that. May I just hold my points until the end of the meeting, if I may?
Okay, no
because
problem. Yeah.
I'd like just to move slightly off the topic of TB when we do say that.
Okay.
So thank you for now.
Okay, no problem. I'll ask Dr. Manikchand to give her thoughts about this. Yashoda, please.
Yes, evening everyone. Thanks, Danelle. That was a good presentation, and thanks as always to Prof. Hadley for his really gold input. So I have yet another take on TB. I think, yes, I think all South African doctors, or maybe even African doctors, are experts on TB now. If you've been through med school, like Prof. Hadley says, everything could be seen as, I mean, every differential should include TB, and we've seen so much of it. But I also want to remind everyone that it's an opportunistic infection, and that what our real, the foundational problem is that our immune systems, well, the people who manifest the TB symptoms and signs, their immune systems are not well equipped, and so they manifest TB. We all have been, invariably, we've been exposed. So if you take x-rays of all of us who are health workers and have been exposed to TB in hospitals, I'm sure you'd find a gun focus here and there in our x-rays, but just a reminder of that. And obviously we've seen much more because of our conditions, our living conditions, and how it affects our immune systems, and the HIV that's so prevalent now. And we see it in the children who are on chemotherapy, so our oncology patients as well. So it's important to keep them in mind for our patients. The other thing I wanted to just say is that we are often, as surgeons, we don't see a lot of TB unless it's, in our differential, or we are referred patients who have lymphadenopathy that lymphoma needs to be excluded. So I think it's been mentioned, but just to remember this, because there's a child now in our oncology ward who has Burkitt's lymphoma, who you could have easily thought had TB lymphadenitis or scrofula, like Prof. Hadley calls it. So it's really imperative that we think about lymphoma, even with the patients that we query TB with. And often we will be the ones who need to do the lymph node biopsies. And if we are querying lymphoma, then we need a whole lymph node. So there's often a bit of a conundrum when we have these scrofula patients or these lymphadenitis patients, where if you cut into it, it's going to cause a fistula. If it's TB, it won't heal. But at the same time, if you're looking for lymphoma, you should actually get a whole lymph node out for the diagnosis. So I'd like to hear if any of our senior surgeons like Prof. Hadley and Prof. Lazarus have any tips on this, because they often have the same symptoms. The pediatricians, when they've started the TB treatment already, then it's easier to say, yes, a lymph node biopsy is definitely needed. But there have been patients that have been on the table and I put a needle in and got caseous material. So we obviously can't be doing lymph node biopsies on every patient with lymphadenitis, because that we would be doing that every day, all day. So I would like to hear if there's any advice on that from them. And then my last comment is that now we're seeing TB meningitis in these children, and unfortunately they're coming in quite late, and they've had quite late complications of the TB meningitis, and it's too late to reverse the basically irreversible damage from the TB meningitis. And now we're starting to see them more, where we have to put gastrostomies in and do fundoplications in a lot of them because of the higher neurological fallout. So that's something we're starting to see as well. But yes, thank you. Those are my comments.
Okay, thank you, Yashoda. I wonder whether Professor Hadley wants to answer Yashoda's query, Prof.
Yeah, thanks. You do need a complete lymph node to diagnose and to type lymphoma, but you do not need a full lymph node to diagnose tuberculosis. So before putting the patient on the table for a lymph node biopsy, do a fine needle aspiration. If it's TB, you can make the diagnosis without taking the patient to the operating room. In fact, I would strongly suggest that our pediatricians shouldn't actually refer people for a lymph node biopsy until they've done a fine needle aspiration.
Yeah, thanks, Prof. Yes, that has been our agreement, on discussion with them, but often those come back as inconclusive, and maybe they're not doing it strictly, but we don't do the FNABs. They come in with, a cytology that is inconclusive, or, Yeah,
the nice thing about fine needle aspiration cytology is it can be repeated. And it is If you're seeing
Yes.
the patient in an outpatient situation, or you're seeing the patient in the ward, you can quickly do it and make sure it's been done properly before, because the whole lymph node biopsy is a very invasive procedure, and it's not as easy. It's not as easy as we pretend. I mean, I know it's usually left to the most junior registrar on the team, but it can be a very difficult operation, and I would much rather my patients avoided that when it was unnecessary.
Agreed. Yes. And yes, maybe we should be doing more FNABs than we are doing lymph node biopsies then.
Colin, are you doing the same? I mean, is it? Am I out of line here with your thinking?
No, Larry, you're not out of line, though I will confess I'd like to say that the experience that I've had in recent years has been just a lesser exposure to tuberculosis than when I was on the floor in the public sector. And I'd like to come back to that at the end, if I may. Thank you.
Okay, Colin. I'd like to invite Dr. Majola. Dr. Majola, your comments. I know you could join only later, but whatever comments you have on the subject.
Hi, Prof. Thanks for the opportunity, but yeah, because I missed the whole talk. I only managed to hear Prof. Hadley's brilliant slides, which is very insightful and helpful. Thank you very much. But also just to mention that some of the swellings, I would say, with these kids is what we've always been taught, especially from med school, which is always ringing in our head is, if you don't know, you always say TB, what just Prof. Hadley said, but also the difference that with TB, you always get what we call cold abscesses, which we're taught never to stick anything into them because of the risk of fistulations. But yeah, it becomes a difficult conundrum per se when you just have this solid mass which is not responding per se to whatever antibiotics that the pediatricians had started, and now we are left to decide as to what the next phase of diagnosis per se is. But I've always then add on final aspiration first, and if that is inconclusive, then I would take for an open biopsy to get a tissue specimen. Thank you.
Thank you, Kuruleko. I see Professor Arturo Delgado is also here. Arturo, do you have any comments about your experience of TB in UMTATA?
Actually, we don't see too many children with TB here. But what I can say is the problem with the fine needle aspiration and the lab. The most of the time come at the state is common, that's inconclusive. So we aim to do open and do a biopsy. But I don't see that this is a problem of the procedure, it's a problem of the lab. Thank you, Miriam.
Okay, thank you, Arturo. Thank you. Before I invite Professor Lazarus, I just want to caution, I mean, the title of the topic is TB and Pediatric Surgeon. So we children's doctor are probably a little bit lucky because children rarely get cavitatory pulmonary TB. So we are less exposed to the infectious type of TB. But I mean, within our hospital, the doctors we know, there are at least 3 or 4 doctors currently working with us who have had TB. And I have personal friends who are doctors who have had multi-drug resistant TB and extremely drug resistant TB. So it is a reality. We all are exposed to it, and we must take special precautions when necessary. So I'll just ask Professor Colin Lazarus to give his thoughts. Colin?
So thank you, Milind. And now it's just a slight, it's on a tangent, but it's with an opportunity of having someone like Larry Hadley present in our meeting. And the point is that, as we know, Larry has over many years published articles relating to pediatric surgery on a whole variety of topics. And we recognize him for what he is as a world expert on so many topics. And to a large extent, that's come because he has published. He has looked at the information that he's had, and he has drawn our attention to many aspects of common conditions that we'd not perhaps thought about, but which has come about because of that experience. Just on the issue of TB, you'd mentioned that there was a time when we did a lot of TB spines, and it was in the late 1980s, so it seems a very long time ago, that the three senior surgeons at Cecilia Makiwane published our experience with tuberculosis of the spine. Two papers. One was the first 300 cases that we'd seen at Cecilia Makiwane, and the other was of 280 patients with what we called POTS paraplegia that either Jack Adendorf had seen at Mount Coke Hospital, where he'd worked for many years, or we had seen at Cecilia Makiwane. Now, that was enormous experience. And we'd worked with these patients, and so unquestionably we'd become great experts, and we'd read a lot about it. And we did have something to contribute. The point I'm making is that in our experience here in East London in particular, but wherever we are encountering things that we ought to be looking at. When we see a lot of some things, or we see some things that are unusual, we should be thinking a little further than just what is the diagnosis and the patient has left us now after we've done our management, but seeing how we can collate those things. Jack Adendorf had kept records of all his tuberculosis of the spine patients from the Mission Hospital, and we kept records at Cecilia at that time. And we were able to publish, and it allowed us to become, inverted commas, experts on that subject, as Larry has on many, many others. And I think the challenge of hearing this excellent talk, two excellent talks today, but the excellent talk from Larry is also just a reminder of what perhaps we should be aiming at as a unit. And that's my message, that we need to really reinforce that fourth pillar of an academic hospital, of academic department, which is in research and looking at the work we do more thoroughly than perhaps has been our habit. Thank you very much indeed.
Yes.
Milind, can I chip in there?
Please.
After all Colin's very flattering remarks, he just made me sound terribly, terribly old. But it all starts from records. You've got to keep records, and if there's one thing that we should be spending our research money on, it's on data management and collating it. And I was very lucky to have Eleanor. You will remember Eleanor, and lots of the audience will remember Eleanor, who was fastidious about keeping our clinical records. And forget the hospital system. The hospital system will let you down more often than it will help you. So you've got to do it yourself. And unfortunately, there's no shortcut. Putting these things out actually is a lot of hard work. As Colin's just said, Adendorf kept all his own records. And Cecilia Makiwane, they kept their own records. And if you don't put in the hard graft, unfortunately, you won't get the results. And I look around the Yashoda's MEd thesis, purely from data that we gathered for ourselves, quite separate from the hospital records. So I think once you've got a data management system in place, then everything else is easy. So data management is the hard part. Start now.
Yes. Thank you, Prof.
Can I just interject
Yes,
there
please,
briefly?
please. Yes.
Yeah, I'm glad Prof. Hadley and Prof. Lazarus have spoken about this, because we've been collecting our data, but we don't have a data capture. The registrars are doing that. The registrars and the MOs are doing that, and I want them to hear how important it is for us to collect that data. And even though it's extra work, it really pays off in the end, and we can do the research, we can publish, and we can also improve our services. So I'm glad they both brought that up.
Yes, thank you, Yashoda. And I'm glad that you are driving that process in our department. And finally, more than 2 years ago, we have an electronic, at least operation record system, which is functioning quite well. So I think there's a lot of scope for us to improve and build the fourth pillar of our department, which is the research component, which we are currently addressing. I think if there are any questions, we can ask questions either to Daniel or to Prof. Hadley or Lazarus. If no questions, then we can conclude the meeting. Any questions? I don't see any questions. So thank you very much. Again, I'm glad that we are finishing exactly in 60 minutes time, despite of this excellent discussion and advice and information. So thank you for all attending. Thank you, Prof. Hadley. We always appreciate your presence. And thank you, Prof. Lazarus. We will see you next week. And next week will be part 2 of long gap esophageal atresia. So it will be a talk by Dr. Gautam on esophageal replacement. And we hope to get Professor Samad Sheikh as our invited guest. Thank you all. We'll see you in a week's time. Bye-bye now.
Ciao, Milind.
Bye.
Thanks, Larry. Thanks, Milind, and everybody.